The key features of the posterior abdominal wall. Somebody please tell me the organization of posterior abdominal wall. What structures are there? Which muscles are there? Then what covers those muscles? And what lies in front of those muscles? Psoas major, psoas minor, then quadratus lumborum. Alright, lateral to it is the quadratus lumborum. Alright. Where from the quadratus lumborum originates and where does it go? Psoas major and the quadratus lumborum is under the anterior layer of thoracolumbar fascia. Alright. That is beneath the thoracolumbar fascia, anterior layer of thoracolumbar. Psoas fascia covering the quadratus lumborum. Together they make the anterior layer of thoracolumbar fascia. Alright. That in between the anterior and intermediate layer, the quadratus lumborum muscle passes up to the lower quarter of 12th rib. That is quadratus lumborum. Alright. Then in front of that is the thoracolumbar fascia or the psoas fascia. Beneath that is in front, from the abdomen side, what do you get there? What will you see? First you have to identify the medial arcuate ligament. First you have to identify the medial arcuate ligament. Alright, between the right and left crus of the diaphragm. Where you can find the, on the left side, left abdominal aorta, in between the cisternal chyli, and on the right side, the lumbar azygos vein. Alright. And lumbar azygos vein is connecting with the inferior vena cava, IVC. Alright. So IVC on the right side, abdominal aorta on the left side, and in between there is the cisterna chyli. Alright. This is under the medial arcuate ligament. Then from the medial arcuate ligament, there is another ligament called the medial arcuate ligament. And there is the lateral arcuate ligament. There is the lumbocostal arch. Alright. From the deep to the lumbocostal arch, that is the lateral arcuate ligament, there will be the subcostal vessels and nerve. Subcostal vessels and nerve. The subcostal vessels and nerve passes deep to the kidney. Have you seen? Dissection of abdomen. If you lift up the kidney, there will be three structures coming out laterally, downwards and laterally forward. Alright. These are the subcostal vein, artery and nerve. Below the subcostal vessels, you will find two other nerves. That is the iliohypogastric and ilioinguinal nerve. Why ilioinguinal nerve? Why ilioinguinal nerve is important? Why ilioinguinal nerve is important? It is an important structure while you do the hernia operation. It is an important structure while you do the hernia operation. Ilioinguinal nerve doesn't pass through the deep ring. Ilioinguinal nerve doesn't pass through the deep ring. Rather, it comes from the front and pierces the fleshy part of the internal oblique muscle. Alright, what we do during hernia operation, what we do, we make a parallel incision parallel to the 2.5 centimeter parallel to the inguinal ligament. Alright, then we start splitting. We don't incise the muscles. Alright, then we have the understanding of the external oblique muscle. External oblique muscles কিরকম আছে এরকম করে আছে, ঠিক আছে? So we start splitting the external oblique muscle. Then deep to it we split the internal oblique muscle in the 90-degree direction. Alright. When we see the canal, content of the canal, then we retract these muscles from above the canal. Alright. These muscles are pulled upward and medially. Then we will see the spermatic cord with the ilioinguinal. Spermatic cord with the ilioinguinal nerve, which doesn't pass through the deep ring and comes out through the superficial inguinal ring. Right? And we identify the spermatic cord because due to the loops of the internal oblique muscle. The spermatic cord, that is the cremasteric muscles. Alright. Now the ilioinguinal nerve will go to supply the upper part of the skin of the thigh, upper and medial part of the skin of the thigh, skin of the penis and root of the scrotum, root of the penis and the scrotum, together with, if it is a female, then the mons pubis, labia majora and the round ligament of uterus. Alright, this is done by the ilioinguinal nerve. This is done close to the 2 to 2.5 centimeter medial to the anterior superior iliac spine. Now you know where I am going to incise, where I am putting the incision. Alright, this will be parallel to the inguinal ligament and roughly 2 to 2.5 centimeter medial to the anterior superior iliac spine. Right? Now iliohypogastric nerve is a little above to the ilioinguinal nerve. It is also 2 centimeter in front medial to the anterior superior iliac spine, but ilioinguinal nerve is lower than the iliohypogastric nerve. First, this pierces the transversus abdominis muscle, then lies in between the transversus abdominis and internal oblique muscles. Then it pierces the internal fleshy part of the internal oblique muscles, comes out and gives out two branches, lateral and anterior. The lateral branch passes the anterior superior iliac spine close to the iliac tubercle and goes to the gluteal region. And the anterior branch that comes out piercing the internal oblique as well as the aponeurosis of the external oblique, supplying the skin of this region. Now I know where the lateral branch of the iliohypogastric nerve is going to the gluteal region, crossing over the iliac crest, behind the tubercle of the iliac crest, going to supply the muscles of the gluteus region and skin of the gluteal region. And the anterior branch that is running in between the transversus abdominis and the internal oblique, piercing the fleshy part of the internal oblique and coming out piercing the external oblique aponeurosis around 3 centimeter above the superficial inguinal ring. Now you know where I am operating completely. You will not handle the inguinal nerve within the canal, ilioinguinal nerve within the canal. You will keep it aside. Then go on performing the operation, that is cutting of the widening of the inguinal canal, and finally you stitch out the conjoint tendon with the internal oblique and the transversus abdominis. You make it close. Remember, during operation, first thing you do is, if there is any content in the scrotal sac, you first take out things, anything that is within the scrotal sac, so that you can pull out the sac content through the superficial ring, and next to the, from the superficial ring, these contents are pulled out towards the abdomen, and when it comes out, there will be a gargling sound and the content will be pushed inside the abdomen through the deep ring. The content will go through the deep ring into the abdomen, will return back. Alright. If it doesn't happen, you have skimmed the content, you have skimmed the content of the cord, and the content of the cord will come towards the deep ring, and there will be a gargling sound, so that the gut with its content will enter the abdomen. If it doesn't happen, that means there is some incarceration. There is some incarceration, adhesion and blocking of the lumen of the gut tube. Understood? There is block in the lumen of the gut tube. So, you should be careful in prior hand that I have to relieve the gut tube. Then I will close the hernial side. Gut tube whatever is there in the gut tube, you have to take it out, take it back into the peritoneal cavity through the deep ring. So you have to see whether the canal content is passing through the deep ring or not. Because the ilioinguinal nerve is not a content of the inguinal canal. It will pass through the superficial inguinal ring. Alright, so you have to check whether this content of the canal is coming deep to the abdomen, back deep to the deep ring, deep inguinal ring. Right? When it is done, then you put blind stitches closing the conjoint tendon and the anterior part of the inguinal ligament. You make deep stitches, alright, so that this part becomes narrow. When you take out this material, then you put the conjoint tendon will be fixed to the pubis and external oblique muscle, so that this part is strengthened. The posterior wall of the hernial canal is strengthened by putting bite, taking the symphysis pubis and the inguinal ligament. Conjoint tendon fibers এরকম করে রয়েছে, এটা symphysis pubis. Alright, this one is the symphysis pubis, this is the conjoint tendon on the pubic crest. And then, as you know, that the lateral 2/3 is giving the internal oblique. At first it is anterior, then is backward, and then arched. And this part with the transversal abdominis forms the conjoint tendon. Understood? This conjoint tendon will be fixed with the pubic crest. Alright, so that the aperture or the passage is made narrow. But before doing this, what will you do? You will skin the gut, whether anything is there which will not pass through the deep ring. What is the problem? Before you put repairing stitches, what you need to clear that whether there is nothing in the herniated gut that will not pass through the deep ring. If it is clean, then there will be gargling sound, and the herniated gut will come back to the abdomen. Then we put the strengthening of the medial wall through the stitching of the conjoint tendon at the pubic crest. Got my point? You understood? So here is the importance of two nerve, that is the ilioinguinal nerve and the iliohypogastric nerve. Alright. Roughly tell me the nerves that come out from the lumbar plexus. When we read about the somatic nerve, you need to know that the autonomic fibers that are coming along the lumbar part of the sympathetic trunk, the upper 3 to 4, there are sympathetic ganglia. From the sympathetic ganglia, there are two communications to each lumbar nerve. Number one, that comes to the from the nerve that comes to the sympathetic ganglia, and from the sympathetic ganglia the fiber that goes to the ventral rami of the spinal nerve. Got my point? From each spinal nerve there will be one communication to the sympathetic ganglia, that is the grey rami communicates, and from there will be white rami communicates to the ventral rami of the spinal nerve. Got my point? Number one, above one, that is the subcostal nerve, that is the T12, that I have been talking about, deep to the kidney. What the quadratus lumborum, running downwards and lateral. That is the subcostal nerve and vessels, alright. Deep below that, there is the subcostal nerve gives a tweak to the L1 nerve, alright. And these divides into, you see, ilioinguinal and iliohypogastric nerve. This one, above one is the iliohypogastric nerve and below one is the ilioinguinal nerve. Alright. Next, we see the common nerve taking origin from the L1 and L2. L1 and L2, this giving rise to the genitofemoral nerve. Alright. As the name suggests, there will be a genital component and there will be a femoral component. Got my point? Could you follow? Genitofemoral means there will be a genital component and there will be a femoral component. The femoral component supplies the upper and medial part of the thigh, and the genital component supplies the root of the penis, scrotum, and in case of female, ground ligament of uterus together with the cremastetic fibers in both the sexes. Alright. So this is the genitofemoral nerve. Next comes the lateral femoral cutaneous nerve, that is L1 and L2. The blue color suggests that these are the dorsal branches of the ventral rami. The blue color suggests that these are the dorsal branches of ventral rami. So the lateral femoral cutaneous nerve is the dorsal branches of the ventral rami of L1 and L2. For lateral femoral cutaneous nerve, L2 and L3. And for femoral nerve, it is L2, L3, L4. And for the obturator nerve, it will be ventral rami of ventral branches of L2, L3, L4. Ventral rami branches of ventral rami of L2, L3, L4. Alright. Now one more nerve needs to be, the ilio needs to be described a little more. What is that? That is the obturator nerve. Alright. Obturator nerve comes out. All these ilioinguinal, iliohypogastric, these nerves come out from the lateral border of the psoas major. From the lateral border of psoas major. Psoas major muscle is like this. Psoas major muscle is like this. One muscle is like this, another muscle is like this. Alright. So these nerves are coming through the lateral border of the psoas major muscle. Through the lateral border of the psoas major muscle. Whereas the obturator nerve comes out through the medial border of the psoas major muscle. What is the basic difference? All these nerves are coming out through the lateral border of the psoas major muscle, whereas obturator nerve is coming through the medial border of the psoas major muscle. All right. Do you have the understanding of the pelvic surface of the sacrum? What is the relation of the pelvic surface of the sacrum? Sacrum is like this. It is smoothly carved ventrally. Alright. The upper one is the junction between the L5 and the body of the S1 vertebra. Upper one is the S1 vertebra and the junction of the L4, L5 and S1 vertebra. Alright. And on either side, this gives rise to ala of sacrum. This gives rise to ala of sacrum. Ventrally, there are ridges in between the sacral foramina. There are 4 pairs of sacral foramina, and there are ridges in between that. On the anterior margin of the ala of sacrum on either side, there are few structures. We memorize it by the mnemonic OILS. O is the obturator nerve at the Anterolateral angle of the sacrum of ala of sacrum, OI. Then internal pudendal vessels, L is iliolumbar I, OI, L. The mnemonic is oils, O for obturator nerve, I for internal iliac vessels. L for, what is standing for L? Somebody please tell me what is standing for L. The mnemonic is oils, O is obturator nerve, I is internal pudendal vessels. L is what? S is sympathetic trunk. What is L? Now taking the 3, that is in between the 4 pelvic foramina, there is the coccygeus muscle. All right, and at the lower part, that is the inferolateral part of the sacrum, there is the piriformis muscle. So piriformis and the coccygeus muscle, and below, from below, we will see the gluteus maximus muscle. ठीक है? You haven't studied the sacrum? No. There lies the problem. How will you identify the structures? I am not interested in any greater elaborated explanation of this nerve, course of the nerves. All right. I am only interested in the structures around. How can you find all those structures, reach all those structures? Anyway, there is another thing, that is the autonomic fibers that are coming along with this lumbar spinal nerves. Autonomic nerves that are coming along with this lumbar spinal nerve. As you see, the T12 nerve is giving a tweak. Second row is the internal pudendal vessels, or internal pudendal nerve. Iliolumbar artery, there will be iliolumbar artery. S is the sympathetic trunk. On either side, there is the sympathetic trunk. All right. And you see, the sympathetic trunk is communicated. I is the iliolumbar artery, as I can recall. Okay? Somebody please cross check the relation of the ala of sacrum on the pelvic aspect. Anyway, S is the sympathetic trunk. Now, this is the ganglionated sympathetic trunk, and from each spinal nerve there is a grey rami communicant, and from there is a white rami communicant to the ventral rami of the spinal nerve. All right. Both are present in the upper 3 or 4 sympathetic ganglia, and this is absent on the lower part. That is the 4th or 5th sympathetic ganglia doesn't provide both the sympathetic grey rami and the white rami communicants. All right. The grey rami gives the preganglionic motor fibers. Grey rami gives the preganglionic motor fibers and some viscerosensory fibers, whereas the white rami gives rise to the postganglionic, viscerosensory as well as the motor fibers to the blood vessels, piloerector muscles, motor fibers to the blood vessels, piloerector muscles, and the pseudomotor fibers. Preganglionic fibers is giving the preganglionic sympathetic fibers and viscerosensory fibers, and the white rami is giving rise to the postganglionic, visceromotor and the unmyelinated pseudomotor fibers. Now, in case when there is excessive sympathetic outflow through this lumbar sympathetic system, in case there is excessive sympathetic outflow through this lumbar sympathetic system, what will happen? There will be vasospastic disease. Write it down. In case of excessive outflow through the lumbar sympathetic trunk, there will be a vasospastic disorder. There will be vasospastic disorder which is known as Barger's disease. B-E-R-G-E-R apostrophe Barger's disease. In Barger's disease, what happens? There is, at first, it begins with the intermittent claudication. Intermittent claudication. Then, when it is continuous, then it becomes resting pain. So, Barger's disease begins with the intermittent claudication. Then, there will be rest pain. And then, there will be continuous pain in the limb. And finally, there will be necrosis of the tissues. This is known as Barger's disease or thromboangiitis obliterans. Thromboangiitis obliterans or Barger's disease. What we need to do? We need to do sympatherectomy of one side first, then bilateral of the next part. To prevent the progress of the Barger's disease or the thromboangiitis obliterans, we need to do lumbar sympatherectomy, or that is the removal of the lumbar sympathetic trunk together with the ganglion. Alright. Then if there is accessory sympathetic ganglion, this operation will not be a fruitful case. But we do bilateral lumbar sympatherectomy to prevent the spasticity of the blood vessels and thereby the claudication, that is the pain, intermittent pain and the rest pain. Alright, you also know, or together with Barger's disease, you also need to know what is Raynaud's phenomenon. What is Raynaud's phenomenon? শুধু Barger's disease জানলে হবে না, তার সঙ্গে Raynaud's phenomenonটাও জানতে হবে, and you have to be able, you should be able to differentiate the Barger's disease from the Raynaud's phenomenon. Okay, I will continue lumbar plexus in connection with sacral plexus together. Alright, lumbar plexus together with sacral plexus, that is the lumbosacral plexus. Here you can see that the fourth spinal nerve gives one larger branch that connects with the L5 nerve that is going to form the lumbosacral plexus. Fourth spinal nerve, one smaller part is joining the lumbar plexus and the larger part downwards joining the L5 and thereby forming the sacral plexus, and this is known as the lumbosacral trunk. This is known as the L4, the larger downward part of the L4 nerve, L4 spinal nerve is known as the lumbosacral trunk.